Somewhere in America right now, a person over 50 is sitting in a doctor's office, being told their blood pressure is too high. They receive a prescription, a reminder about sodium, and an appointment for 3 months from now. What they do not receive is an answer to the only question that actually matters. Why? Not why blood pressure is dangerous. They know that. Why theirs is high. What specific biological process, running beneath the surface of a number that takes seconds to measure, is responsible for what's happening in their arteries? That question, in most clinical settings, is never asked, and the cost of not asking it is paid slowly, quietly, over years. Here is what the research has established, with enough clarity to change how you think about this. Hypertension is not one condition. It is a destination that at least 6 distinct biological mechanisms can reach independently. And the standard treatment protocol is designed to address exactly one of them. The other 5 continue. In some people, all 6 are operating simultaneously, compounding each other through pathways that connect the gut to the arteries, the quality of sleep to the behavior of stress hormones, the state of metabolic health to the structural integrity of blood vessel walls. The implications of that gap are not abstract. They show up in patients whose pressure resists 3 different medications without anyone investigating why. They show up in people whose numbers are controlled on paper while the underlying biology continues its work undisturbed. They show up in the distance between what the science knows and what the average appointment has time to say. This video covers all 6 root causes: what they are, how they operate, what the research shows, and what changes when a patient understands them well enough to ask better questions. No sensationalism, no shortcuts, just the science, translated into language that respects your intelligence and your time. There's a number your doctor watches more closely than almost any other. It appears on a cuff, takes seconds to measure, and has become so central to modern medicine that most people over 50 have memorized their own reading the way they memorize their phone number. But here's what almost nobody explains. That number is not a disease. It's a report. It's your cardiovascular system telling you something about what's happening deeper inside. And the question that rarely gets asked in a 15-minute appointment is what exactly is causing it to say what it's saying. Blood pressure, at its most basic, is the force your blood exerts against the walls of your arteries as your heart pumps. The American Heart Association defines high blood pressure, or hypertension, as a consistent reading at or above 130/80. That threshold exists because above it, the mechanical stress on arterial walls begins to accumulate damage over time, to the vessels themselves, to the kidneys that filter your blood, to the small arteries feeding your brain, and to the heart muscle working harder than it should have to. The number matters. Nobody serious is arguing otherwise. But the number is downstream of something. It doesn't appear out of nowhere. Think of it this way. If the engine warning light comes on in your car, you can cover the light with tape. The dashboard goes dark. The problem doesn't. Modern hypertension treatment, at its best, does far more than tape over a light. Antihypertensive medications are genuinely effective at reducing cardiovascular risk, and for many people, they are absolutely the right intervention. But medication that lowers the number without addressing what's driving the number is, by definition, incomplete. It manages. It doesn't always resolve. And for a significant portion of patients, the root cause of their high blood pressure is never identified, never discussed, and certainly never treated. Here is what the research shows and what your next appointment probably won't cover. Hypertension is not one condition. It is a final common pathway, a place where several very different biological processes can arrive at the same destination. Arterial stiffness gets you there. A dysregulated hormonal system gets you there. Metabolic dysfunction gets you there. Chronic inflammation gets you there. An imbalanced gut microbiome gets you there. Disrupted sleep gets you there. 6 distinct mechanisms, each with its own biology, its own early warning signs, and, critically, its own most effective response. Your doctor is almost certainly treating the destination. What this video is about is the roads. Most people living with hypertension have been told what they have, given a prescription, told to reduce sodium and exercise more, and sent home. That's not negligence. It's the reality of how modern primary care operates under time and resource constraints. But you are not a 15-minute appointment. You are someone who wants to understand what's actually happening in your own body. And that understanding is where real decisions get made. So let's start at the beginning, with the arteries themselves, and with a process of aging that most people don't know can be accelerated, slowed, and in some cases partially reversed. Picture a garden hose that has been left in the sun for years. The rubber that was once flexible enough to coil and bend without resistance has become stiff, brittle, slightly cracked at the edges. Water moving through it now meets a different kind of resistance than it did when the hose was new. Not because the water pressure changed, but because the walls stopped yielding the way they used to. Your arteries, over the course of a lifetime, undergo a version of that same process. And in many people over 50, that process is happening faster than it should. Not because of age alone, but because of factors that are measurable, understandable, and in meaningful ways, modifiable. Arterial stiffness is one of the most well-documented contributors to elevated blood pressure in older adults, and it operates through a mechanism that is worth understanding in some detail. Healthy arteries are elastic. When your heart contracts and sends a surge of blood outward, a flexible artery absorbs some of that force by expanding slightly, then recoils, acting almost like a second pump, smoothing the flow. A stiff artery can't do that. It transmits the full force of each heartbeat directly downstream, which means the pressure registered at the cuff is higher. The heart works harder against greater resistance, and the small vessels in organs like the kidneys and brain absorb mechanical stress they were never designed to handle continuously. The European Heart Journal has described arterial stiffness, measured by a value called pulse wave velocity, as an independent predictor of cardiovascular events, meaning it predicts heart attack and stroke risk above and beyond what blood pressure readings alone can capture. What accelerates this stiffening? Several things converge here, and the list is more familiar than it might seem. Chronic high blood sugar damages the proteins that give arterial walls their elasticity. A process called glycation, where sugar molecules essentially bind to and degrade structural tissue. Oxidative stress, which is an imbalance between damaging molecules in the bloodstream and the body's ability to neutralize them, degrades the inner lining of blood vessels, a tissue called the endothelium, which plays a central role in keeping arteries responsive and relaxed. Chronic low-level inflammation, which will come up again later in this video in its own right, accelerates the deposition of calcium in arterial walls, a process that has nothing to do with dietary calcium and everything to do with inflammatory signaling gone wrong. Each of these processes compounds the others, and together they produce arteries that are older, biologically, than the person they belong to. The reason this matters beyond the mechanics is that arterial stiffness responds to intervention in ways that pure pharmaceutical pressure management often doesn't address. Regular aerobic exercise, specifically the kind that elevates heart rate sustainably over time, has been shown in multiple studies to improve arterial compliance, which is the technical term for an artery's ability to expand and recoil properly. The mechanism appears to involve increased production of nitric oxide, a molecule the endothelium releases to signal the surrounding muscle to relax. Omega-3 fatty acids, found in fatty fish, have demonstrated measurable effects on vascular elasticity in controlled trials. Even certain dietary patterns, particularly those that reduce advanced glycation end products, which are compounds formed when food is cooked at very high temperatures, show associations with slower vascular aging in observational research. None of this replaces medication when medication is warranted, but it addresses something medication typically does not. There is a particular frustration embedded in this cause root that's worth naming directly. Arterial stiffness develops silently, over decades, long before it shows up on a blood pressure cuff. By the time hypertension is diagnosed, the vascular remodeling that contributed to it has often been underway for years. That's not a reason for despair. It's a reason for a different kind of attention going forward, because the biology that hardens arteries doesn't stop responding to the right signals just because it's been running in the wrong direction for a while. The next cause route is different in its origin, but equally invisible in its early stages. And it involves a hormonal system that most people have never heard of, quietly controlling how much fluid your body decides to hold on to. Most people, when they think about blood pressure and sodium, picture a salt shaker. They've been told to use it less, and that advice isn't wrong. But it's incomplete in a way that has led millions of people to either over-restrict salt unnecessarily or conclude that since they already eat carefully, sodium can't possibly be their problem. The real story isn't about the salt shaker at all. It's about a hormonal cascade running quietly in the background of your physiology. One that determines how your kidneys handle sodium in the first place. And when that cascade malfunctions, it doesn't matter much whether you're salting your food or not. The system is called the renin-angiotensin-aldosterone system, or RAAS, and it is one of the body's primary mechanisms for regulating blood pressure and fluid balance. Here is how it works when functioning correctly. When blood pressure drops, say after dehydration or blood loss, the kidneys detect the change and release an enzyme called renin. Renin triggers a chain reaction that eventually produces a hormone called aldosterone, which signals the kidneys to retain sodium and water, increasing blood volume and, with it, pressure. It's an elegant feedback loop designed to keep you from losing pressure during a crisis. The problem arises when the system becomes chronically overactivated, stuck in a state of unnecessary alarm, continuously signaling the kidneys to hold on to sodium and fluid even when there is no crisis, no deficit, no biological reason to do so. Chronic RAAS overactivation has several known triggers, and they tend to cluster in people over 50 in ways that are not coincidental. Excess visceral fat, the fat stored around abdominal organs rather than under the skin, produces inflammatory signals that dysregulate the system. Chronic stress keeps the adrenal glands, which produce aldosterone, in a state of elevated output. And in a smaller but clinically significant subset of people, a benign tumor on one of the adrenal glands produces aldosterone autonomously, flooding the system regardless of what blood pressure is doing. This condition, called primary aldosteronism, is estimated by research published in the Journal of the American Medical Association to affect somewhere between 5 and 10% of all hypertensive patients, a figure that makes it one of the most common yet underdiagnosed secondary causes of high blood pressure in clinical practice. This is where the sodium conversation becomes genuinely interesting. When RAAS is overactivated, the kidneys are already primed to retain sodium aggressively. In that context, dietary sodium acts like fuel added to a fire that's already burning. Reducing intake helps, but it doesn't address the mechanism driving the retention. The more clinically useful question isn't just how much sodium a person consumes, but why their kidneys are holding on to it so tenaciously. Some people are what researchers call salt-sensitive, meaning their blood pressure responds to sodium changes more dramatically than average. And salt sensitivity itself is now understood to be partly a reflection of underlying RAAS dysfunction, not simply a fixed genetic trait. The National Institute of Diabetes and Digestive and Kidney Diseases notes that this sensitivity increases with age, which is one reason blood pressure tends to climb in the decades after 50, even in people whose diets haven't changed. What makes RAAS dysfunction particularly relevant for someone trying to understand their own blood pressure is that it's one of the few root causes with a relatively accessible diagnostic path. A simple blood test measuring renin and aldosterone levels, along with their ratio, can identify overactivation with reasonable accuracy. And this test is available in most clinical settings, though it's ordered far less often than it probably should be. Several classes of antihypertensive medication work specifically by blocking different points in the RAAS pathway, which means that for people whose hypertension is primarily driven by this mechanism, The right medication isn't just helpful. It's mechanistically targeted in a way that produces meaningfully better outcomes. But there's another cause that sits upstream of RAS in many patients, one that the medical system has historically treated as a separate problem entirely, even though the biological connection between them has been understood for decades. There is a conversation happening in two separate rooms that should have been happening in one room all along. In one room, a cardiologist manages blood pressure. In the other, an endocrinologist or primary care physician monitors blood sugar. The patient moves between them, collecting prescriptions, following instructions, wondering why the numbers in both rooms keep resisting control, despite their best efforts. What neither conversation tends to address explicitly is that the biology in both rooms is, in many cases, the same biology. And insulin resistance sits at the center of it with a kind of quiet authority that the compartmentalized structure of modern medicine has made surprisingly easy to overlook. Insulin resistance is a condition in which the body's cells stop responding normally to insulin, the hormone that allows glucose to enter cells and be used for energy. The pancreas compensates by producing more insulin, and for a while this works. Blood sugar stays relatively controlled while insulin levels climb in the background. That background elevation, however, is not metabolically neutral. High circulating insulin activates the sympathetic nervous system, which is the body's accelerator, raising heart rate, constricting blood vessels, and increasing the force of cardiac output. It also stimulates the kidneys to retain sodium, feeding directly into the RAAS dysfunction discussed earlier. And it promotes the growth of smooth muscle cells in arterial walls, contributing to the structural thickening that raises resistance to blood flow. The result, according to research published in the journal Hypertension, is that insulin-resistant individuals have significantly elevated hypertension risk even before their blood sugar reaches diabetic levels, meaning the metabolic problem is damaging the cardiovascular system years before it shows up on a standard glucose test. The prevalence of this overlap is not a minor footnote. The American Diabetes Association estimates that insulin resistance affects a substantial portion of adults over 50, many of whom have no diabetes diagnosis and may never receive one. They exist in a metabolic middle ground, fasting glucose slightly elevated, waist circumference expanding, triglycerides trending upward, HDL cholesterol trending down, a cluster of findings that clinicians recognize as metabolic syndrome and that research consistently associates with hypertension risk independent of any individual component. A person can have a fasting glucose of 99, technically normal, and still be running chronically elevated insulin levels that are quietly pressurizing their cardiovascular system every hour of every day. The standard blood pressure workup does not include a fasting insulin level. That omission has consequences. What changes when insulin sensitivity improves? The downstream effects are measurable and, for many people, meaningful. Resistance training, the kind that builds and maintains muscle mass, is one of the most effective tools for improving insulin sensitivity because skeletal muscle is the primary site of glucose disposal in the body. More functional muscle means more capacity to clear glucose from the bloodstream without demanding elevated insulin. Dietary changes that reduce glycemic load, not necessarily low carbohydrate in any extreme sense, but structured to avoid the blood sugar spikes that demand repeated large insulin responses, have demonstrated blood pressure reductions in controlled trials that rival, in some cases, the effects of low-dose antihypertensive medication. The NIH has funded research showing that even modest reductions in body weight, particularly visceral fat, produce disproportionate improvements in insulin sensitivity relative to the amount of weight lost. This is a cause route that rewards early attention in a way that few others do, because the window between insulin resistance and its consequences is long enough that intervention genuinely changes trajectory. But it also demands a kind of diagnostic curiosity that the standard annual physical doesn't always provide. If you have been told your blood sugar is fine and your blood pressure is managed, neither statement addresses whether your insulin is running high and silently doing damage in the space between those two measurements. That space is where the next cause route lives as well. One that operates not through hormones or glucose, but through a biological process so pervasive that researchers now consider it a foundational driver of nearly every chronic disease that becomes more common with age. The word inflammation tends to conjure something visible. A swollen ankle, a red and tender wound, the obvious heat of an immune response doing its job. That kind of inflammation is acute, purposeful, and self-limiting. What researchers began documenting with increasing precision over the past 3 decades is something categorically different. A low-level, systemic, chronic inflammatory state that produces none of those visible signals, generates no fever, causes no swelling you can see or feel, and yet exerts continuous biological pressure on the cardiovascular system with consequences that standard hypertension treatment rarely touches. Some researchers have taken to calling it inflammaging, the slow burn of immune dysregulation that accompanies aging and accelerates nearly every chronic disease associated with it. The connection between chronic low-grade inflammation and hypertension operates through a mechanism worth understanding directly. Inflammatory molecules, particularly proteins called cytokines, directly impair endothelial function, which is the ability of the inner lining of blood vessels to produce nitric oxide and signal surrounding muscle to relax. When endothelial function is compromised, arteries lose their capacity to dilate appropriately, and resting vascular tone increases. Research published in the European Heart Journal has identified elevated C-reactive protein, a standard marker of systemic inflammation, as independently associated with incident hypertension in previously normotensive adults, meaning inflammation predicts the development of high blood pressure before it arrives. The pressure doesn't create the inflammation. Increasingly, the evidence suggests it works the other way around. What drives chronic low-grade inflammation in people over 50? Several contributors stand out for their prevalence and their modifiability. Visceral adipose tissue, that same deep abdominal fat connected to insulin resistance, functions as an endocrine organ, continuously secreting inflammatory cytokines into the bloodstream. Periodontal disease, which affects a significant portion of adults over 50 and is rarely connected in patients' minds to cardiovascular risk, introduces a chronic bacterial burden that sustains systemic inflammatory signaling. Chronic psychological stress elevates cortisol, which at persistently high levels promotes inflammatory gene expression. These are not independent variables. They compound each other, and in combination they sustain an inflammatory environment that a blood pressure medication has no mechanism to address. The clinical gap here is measurable and specific. A high-sensitivity C-reactive protein test can detect the low-level elevation characteristic of chronic systemic inflammation. It is inexpensive, widely available, and ordered far less often than its prognostic value would suggest. When elevated, it opens a different clinical conversation. Not just about what medication to add, but about what biological process is sustaining the pressure. The Mediterranean dietary pattern has accumulated more cardiovascular evidence than almost any other dietary approach in the research literature. And a meaningful part of that benefit appears to operate specifically through inflammatory pathways rather than through direct effects on blood pressure numbers alone. There is something worth sitting with before moving forward. Chronic inflammation is not a diagnosis most people receive. It doesn't appear on a discharge summary. Nobody hands you a pamphlet about your cytokine levels. And yet the research suggests it may be one of the most consequential biological states a person over 50 can find themselves in. Not because of what it causes acutely, but because of what it sustains quietly, across multiple systems, over years. The next cause route takes us somewhere most people would never think to look when trying to understand blood pressure. Approximately 25 feet long, populated by trillions of organisms, and only recently recognized by mainstream cardiology as relevant to what happens in your arteries. If you had suggested to a cardiologist 20 years ago that the bacteria living in a patient's gut might be contributing to their high blood pressure, the response would have been polite skepticism. the gut was the gut. The heart was the heart. That skepticism has not aged well. Over the past decade, a growing body of peer-reviewed evidence has mapped specific mechanisms through which the gut microbiome, the vast ecosystem of microorganisms inhabiting the intestinal tract, communicates directly with the cardiovascular system, and disruptions to that ecosystem now appear in the hypertension literature, with a frequency that can no longer be dismissed as coincidental. Picture a woman in her early 60s, careful with her diet, consistent with her medication, genuinely trying. Her blood pressure remains stubbornly elevated despite 2 antihypertensive drugs. Her cardiologist adds a third. Nobody asks about the 3 courses of antibiotics she took over the previous 18 months, or the fact that she stopped eating much fiber after a bout of digestive discomfort. Nobody connects those details to her arteries. They are gut issues, filed in a separate mental category from cardiovascular ones. But the biology doesn't organize itself by medical specialty. And in her case, the gut and the arteries were telling the same story in different languages. The communication channel between them runs through molecules called short-chain fatty acids, produced when beneficial gut bacteria ferment dietary fiber. These compounds interact with receptors in the gut lining and nervous system that help regulate vascular tone, sodium excretion, and sympathetic nervous system activity. Research published in the journal Hypertension demonstrated that animals raised without any gut microbiome developed significantly higher blood pressure than their conventionally colonized counterparts, and that transplanting a dysbiotic microbiome from hypertensive donors into healthy recipients produced measurable pressure elevation. When microbial balance is disrupted, the signals sent to the cardiovascular system push it toward higher pressure through mechanisms no antihypertensive medication was designed to intercept. What disrupts the microbiome in people over 50? Antibiotic use causes significant collateral disruption to microbial diversity that can persist for months. Diets low in fiber deprive beneficial bacteria of their primary fuel source, allowing less beneficial species to dominate. And here is a connection that closes a loop from earlier in this video. The same dietary patterns that drive insulin resistance and systemic inflammation also reliably degrade microbiome diversity, meaning these root causes are not parallel lines running separately toward hypertension, but intersecting forces amplifying each other through shared biological terrain. An analysis in the American Journal of Clinical Nutrition found that higher dietary fiber intake was associated with meaningfully lower systolic blood pressure across large population samples, with effects remaining significant after adjusting for other dietary variables. What makes the gut-blood pressure connection worth understanding is that it reframes something familiar as something consequential. Most people over 50 have some awareness that gut health matters, for digestion, for immunity, perhaps for mood. The idea that what lives in their intestinal tract is also influencing the pressure readings their cardiologist tracks every 3 months adds a layer of interconnection that changes the logic of daily choices. Fiber isn't just about regularity. Fermented foods, kimchi, kefir, plain yogurt, aren't just a trend. They are inputs into a system that, when functioning well, sends the cardiovascular system signals it was designed to receive. The final root cause operates on a different schedule than all the others. It does its damage not during the day, but during the hours when most people assume their body is simply resting. There is an assumption so deeply embedded in how most people think about sleep that it rarely gets examined directly. The assumption is this: sleep is passive. The body goes quiet. The brain powers down to some minimal maintenance mode, and everything simply waits for morning. The cardiovascular research of the past 2 decades has dismantled that assumption with particular thoroughness. Sleep is not a pause in your physiology. It is one of the most active and consequential periods in your body's daily cycle, and what happens to blood pressure during those hours is not incidental to your cardiovascular health. For a significant number of people over 50, it may be the most under-recognized driver of their hypertension. Under normal conditions, blood pressure follows a predictable daily rhythm. During sleep, it drops by roughly 10 to 20% below daytime levels. A phenomenon researchers call nocturnal dipping. This nightly reduction represents a genuine period of cardiovascular recovery, during which the heart works less, arterial walls experience lower mechanical stress, and the autonomic nervous system shifts away from sympathetic dominance toward parasympathetic activity. The American Academy of Sleep Medicine has documented that individuals who fail to achieve this nocturnal dip carry significantly elevated cardiovascular risk independent of their average daytime readings. Two people can have identical clinic blood pressure numbers and face very different cardiovascular futures, depending entirely on what their pressure does while they sleep. The most clinically significant disruptor of nocturnal dipping is obstructive sleep apnea, a condition in which the airway partially or fully collapses during sleep, producing repeated microarousals that activate the sympathetic nervous system dozens or hundreds of times per night. Each arousal triggers a surge of stress hormones and a spike in blood pressure that accumulates across hours the person experiences as sleep, but the cardiovascular system experiences as intermittent crisis. The NIH estimates that sleep apnea affects a substantial proportion of adults over 50, with the majority remaining undiagnosed. Research has shown that treating it with continuous positive airway pressure therapy produces measurable reductions in both nighttime and daytime blood pressure, effects most pronounced in people whose pressure resists multiple medications. Sleep apnea is the most studied disruptor, but not the only one. Chronic sleep insufficiency, consistently fewer than 7 hours per night, activates the stress hormone axis, sustaining sympathetic nervous system tone into hours when it should be receding. A study published in the journal Hypertension found that adults sleeping 6 hours or fewer had significantly higher rates of hypertension than those sleeping 7 to 8, with the association holding after controlling for age, weight, and activity level. Fragmented sleep produces similar effects because the restorative value of sleep depends not just on duration, but on architecture. The cycling through deep slow wave and REM stages that both the brain and cardiovascular system require to genuinely recover. What makes sleep dysfunction particularly consequential as a root cause is that it amplifies every other cause in this video. Poor sleep worsens insulin resistance, elevates inflammatory markers, disrupts the gut microbiome, and accelerates stress-driven hormonal dysregulation. It is not simply one of 6 parallel causes. It is a force multiplier that makes the other 5 harder to control. And yet, a standard hypertension workup rarely includes a structured sleep assessment. A patient can move through 3 medication adjustments without anyone asking how they sleep or whether they wake feeling genuinely restored. That question, quietly asked, has changed the trajectory of more blood pressure cases than most people would expect. Now that all 6 causes are on the table, the most important question is the one that has been waiting since the beginning. Why does the system treat only one of them? And what actually changes when you know about the other 5? It would be easy, at this point in the video, to frame what you've just learned as an indictment of modern medicine. That would be the wrong conclusion, and it wouldn't serve you. The physicians managing hypertension are, by and large, doing exactly what the system they operate within was designed to do: identify elevated pressure, reduce cardiovascular risk efficiently, and move to the next patient. That system has saved an enormous number of lives. Antihypertensive medications are among the most rigorously studied interventions in the history of pharmacology, and their ability to reduce stroke and heart attack risk is not in question. What is worth examining, without hostility, is what the system was designed around and what it was not designed to do. Modern hypertension management was built on a foundation of population-level risk reduction. The landmark clinical trials that established treatment thresholds and medication protocols were designed to answer one question with precision: does lowering blood pressure numbers reduce cardiovascular events across large groups of people? The answer, consistently, is yes. But that question is categorically different from another question: One those trials were never designed to answer. What is causing this specific person's blood pressure to be elevated, and what would happen if that cause were addressed directly? The first question is epidemiological. The second is mechanistic. Medicine became extraordinarily good at the first and structurally under-equipped for the second, not through negligence, but through the logic of how evidence-based guidelines are built and how clinical time is allocated. The consequence for the individual patient is specific and worth naming. A person whose hypertension is primarily driven by sleep apnea may spend years cycling through antihypertensive medications with incomplete response, never having had a sleep study ordered. A person whose pressure is sustained by chronic low-grade inflammation and insulin resistance may be told their metabolic numbers are borderline and sent home without a conversation about what borderline means for their arterial walls over the next decade. A person with primary aldosteronism, that adrenal condition affecting up to 10% of hypertensive patients, according to JAMA research, may go undiagnosed for years while their potassium drops and their pressure remains resistant to standard treatment. In each case, the medication is real. The gap is in the question that wasn't asked before it was prescribed. 6 causes, 1 conversation, and most people living with hypertension will never have it. Subscribe and send this to someone who needs it today. What comes next is where everything you've just heard stops being information and starts being something you can actually use. The research on root cause-informed hypertension management is not speculative. A 2020 analysis in the journal Hypertension found that patients who received evaluation for secondary and contributing causes of elevated blood pressure, beyond the primary diagnosis, achieved better long-term pressure control and required fewer medication adjustments over a 5-year follow-up period. The mechanism isn't mysterious. When the underlying driver is identified and addressed, the cardiovascular system requires less pharmacological force to reach the same destination. That's not an argument against medication. It's an argument for precision, for treating the person rather than just the number. And precision, in medicine as in most things, begins with asking better questions. What remains now is the question this video started with, reframed by everything you've heard since. Not what your blood pressure is, but what it's trying to tell you. There is a particular kind of clarity that arrives when you stop seeing a chronic condition as something happening to you and start seeing it as something your body is communicating. That shift is not semantic. It doesn't minimize the seriousness of what high blood pressure can do. The stroke risk, the cardiac remodeling, the silent kidney damage that accumulates over years of uncontrolled pressure. It doesn't suggest that medication is unnecessary or that lifestyle alone is always sufficient. What it does is change the relationship between a person and their own physiology from passive to active, from recipient to participant. And that change, in the research literature and in clinical practice, consistently produces better outcomes than its absence. What you've encountered in this video is not a collection of alternative theories competing with mainstream cardiology. Every mechanism discussed here, arterial stiffness, RAAS dysregulation, insulin resistance, chronic inflammation, gut dysbiosis, sleep dysfunction, appears in peer-reviewed literature, is recognized by major medical institutions, and in several cases is already the mechanistic target of established medications. The gap is not between conventional medicine and something outside it. The gap is between what the research knows and what the average hypertensive patient is told during the average appointment. That gap exists not because physicians are withholding information, but because the architecture of a 15-minute visit selects for efficiency over depth. And depth is exactly what a chronic condition with 6 distinct root causes requires. Consider what you now carry into your next conversation with a physician that you didn't carry before. You know that blood pressure is a downstream signal, not a primary disease. You know that arterial stiffness responds to aerobic exercise and dietary changes that medication doesn't address. You know that RAAS dysfunction can be identified with a blood test that is rarely ordered. You know that insulin resistance damages arterial walls years before blood sugar becomes clinically abnormal. You know that systemic inflammation, measurable, modifiable, and largely ignored in standard cardiovascular workups, may be sustaining your pressure independently of everything else. You know that your gut microbiome is in active conversation with your cardiovascular system, and that fiber and fermented foods are inputs into that conversation. And you know that what happens to your blood pressure while you sleep may matter as much as what it does when someone puts a cuff on your arm. That is not a small amount to know. The Harvard Medical School has long emphasized that hypertension management is most effective when it addresses the full biological context of the individual patient, not as a critique of pharmacotherapy, but as a recognition that the body is a system, and systems respond better to interventions that understand their architecture. That principle sounds obvious when stated plainly. It is surprisingly rare in practice. Most people living with high blood pressure have been handed a medication, handed a pamphlet about sodium, and left to navigate the rest on their own. This video was built on the belief that you deserve more than a pamphlet, that the science exists, that it's accessible, and that understanding it changes what you do next in ways that matter for how long and how well you live. High blood pressure is not a verdict. It is a signal, specific, biological, and in most cases, traceable to one or more of the mechanisms you now understand. The number on the cuff is real, and it deserves to be taken seriously. But behind that number is a story your body has been trying to tell, possibly for years, in a language that most appointments aren't structured to translate. You now speak a little more of that language than you did 40 minutes ago. Use it. Ask the questions it gives you. Bring it into the rooms where your health decisions get made. And if this conversation opened something for you, if it changed how you think about a number you've been watching for years, subscribe. Share this with 5 people who are watching that same number, and leave a comment telling us what you'd like us to translate next.